Good morning, ladies and gentlemen. My name is Jetnipat Jirajitkarun. Under the supervision of my advisor, today I'm honored to present our study on cost-utility analysis of cervical cancer screening strategy in Thailand. In 2022, cervical cancer ranked as the fourth most common cancer among women worldwide and in Thailand. The primary cause is human papillomavirus infection. And to prevent this disease, Thailand currently employs 7 screening methods, including pap smear, liquid-based cytology, self-sampling tests, and others. However, there is also a novel approach not yet included in the current guideline, the urine HPV test, which offers greater coverage, accessibility, and convenience compared to other methods. Although not yet part of Thailand's screening guideline, a recent study by the UK suggested that urine HPV test could be adopted in the future as a non-invasive and cost-effective option. Urine HPV tests also show performance of 78% sensitivity and 91% specificity, which is on par and even better than some of the current screening methods such as pap smear, liquid-based cytology, and self-HPV DNA test. With this background, our research sought to answer which is the most cost-effective screening strategy in Thailand, with the objective to evaluate the cost-utility of screening strategy in Thailand. We conduct a model-based cost-utility analysis in 2024, targeting Thai women aged 25 to 65 by using a societal perspective and applying 3% annual discount rate for both cost and outcome. Our model then combined a decision tree, which was used to evaluate cost and outcome of each strategy, combining with a Markov model to simulate the natural history of cervical cancer over the lifetime horizon. We then calculate incremental cost-effectiveness ratio, known as ICER, using Thailand willingness to pay threshold of 160,000 Thai baht per quality as the benchmark for cost-effectiveness. And to address uncertainty, both probabilistic and deterministic sensitivity analysis were conducted, along with scenario analysis of existing screening strategy in Thailand guideline and varying screening age and discount rate. Input data were done from systematic review, retrospective cohort study, previous economic analysis, and Singapore hospital record. Key parameters include epidemiological data, disease transition probabilities, test performance, and costs, such as those shown here. Now, for the result of our study. From base case analysis, urine HPV showed the lowest lifetime cost at around 4,300 Thai baht, and pap smear showed the highest lifetime cost of over 25,000 Thai baht. As for effectiveness, clinician HPV DNA test yield the highest quality, while pap smear yield the lowest. On the cost effectiveness plane, both urine HPV and clinician HPV tests were the most cost effective, but only the urine HPV test fell below the cost threshold, with an ICER of approximately 650,000 Thai baht per quality, making urine HPV the most suitable option under Thailand willingness to pay threshold. The incremental cost and quality between urine HPV and other strategies also show that self-HPV DNA test, liquid-based cytology, and pap smear are less cost-effective. And from the sensitivity analysis, this cost-effectiveness acceptability curve show that at Thailand willingness to pay threshold of 160,000 Thai baht per query, represented by the red dot line, the urine HPV test remained the most likely to be cost-effective, with an 87% probabilities. And if Thailand willingness to pay threshold begin to cross over 520,000 Thai baht, shown by the green dot line, clinician HPV test will become the more cost-effective option. This tornado diagram indicated that our results were influenced by correlate rate of self-sampling method, cost of urine HPV test, and HPV incidence. First, scenario analysis showed that when we analyze only existing screening strategy in Thailand guideline, the self-correlated HPV DNA test became the most cost-effective, with an ICER of around 300,000 Thai baht per quality, comparing with clinician HPV DNA test. Second scenario showed that earlier screening from age 30 to 25 increased ICER over 160,000 Thai baht, exceeding Thailand willingness to pay threshold, indicating that the current starting age of 30 is appropriate. Varying the discount rate between 0 to 6% to simulate the economic change also showed that it only produced minor change to the ICER result, which confirmed the robustness of our finding. And Moving to discussion, earlier study in Thai from the year 2011 identified VA with pap smear as the most cost-effective option. And after 2017 National HIV Vaccination Program, along with the new evidence in 2023, the result has shifted, as Thai study indicated that self-collected HPV tests were cost-effective, while a UK study found that urine HPV tests to be cost-saving. Although long-term outcome and the treatment costs were not considered, our study, which incorporated this factor, indicated that urine HPV test is now the most cost-effective strategy in Thailand. As for elimination, we use some international data and assume perfect adherence, which may not fully represent the real-world condition, and treatment pathway will also simplify, so some clinical variation may not be fully captured. In conclusion, urine HPV tests emerge as the most cost-effective strategy, and under current guideline, self-collected HPV tests remain the best available option. Screening at age 30 is considered cost-effective, as screening at age 25 leads to ICER that exceed the Thailand threshold. As for policymakers, according to previous study, urine HPV test has the potential to improve accessibility and coverage among women, especially in the vulnerable group. Our study adds to this evidence by providing strong economic support, showing that urine HPV test is now the most cost-effective strategy. However, the implementation of this strategy should concern about clinical evidence together with other contextual factors to ensure that it fits safely and sustainably within the national health system. Lastly, I would like to thank Shaw Kalapuk Excellent Research Project for medical students from Kaen University, along with my advisor, Professor Laksap Watana Sukchai from Clinical Epidemiological Unit, and Professor Jane Sothonwit from OBGYN Department, which supported me throughout this journey. Thank you for your attention.
Thank you for the great presentations. Any comment or any questions from judges?
Congratulations, very interesting data. If you have a chance to do other study to confirm your conclusion about using the test, what should be done in the future to support the conclusion, to change the strategy in Thailand?
Maybe I would do I would calculate incremental net benefit to show the policymaker how much money they can save, so that the implementation can be visualized from other people who have different perspective from medical.
So thank you so much for the very interesting project presentations. And I just have one question. It's about the performance of the urine test. Is there any varieties of the performance of urine test, and is that you accounted to into the model in a sensitivity analysis, something like that?
You mean the standard error of the sensitivity?
Yes, of course.
Yes, I also included standard error to calculate this too.
So it means is there any varieties of the performance that can happen if you done the test in the different settings? You know what I mean? If you done it in the big hospitals, maybe the performance is really good. But if you go to the very small setting, the performance is really less better.
Okay, so the intervention that I include in study is self-collected HPV test, meaning that they can be collected at home. The one that I use is first void urine test. So I don't think the urine HPV test. We didn't have the comparison in the hospital, because the main reason we use the urine HPV test is because they can do it at home. They don't have to come to the hospital. They don't have to go through that trouble.
All right, thank you very much.
May I?
Okay, we have questions from the online judges.
Yep. Okay, thank you very much. Thank you very much for your wonderful presentation and also very interesting paper. What I would like to ask you is about the availability, since we use the urine test that are not available throughout. If we would like to implement these tests throughout the country, whether the laboratory thing or I mean, maybe how to say the performance of the hospital itself. Can they do the test of the urine throughout the country? Thank you. I mean the laboratory test. Every single laboratory test throughout the country, can they do the urine test? Thank you. Can you hear my voice?
Sorry, can you? Because the voice is kind of like buzzing. Can you say it again?
All right. Yeah, my question is, since you do the test that is not available in Thailand right now, am I correct? Yeah. So if we would like to implement this urine-based test for cervical cancer, do you think the availability of laboratory instrument is support your test? Thank you.
I think for this point we have to look into this after, because as I say that to make sure that this to implement this strategy we have to consider other contextual factor like including the regulatory cost of the implementation cost too. So that we have to look into that in the future too. But thank you anyway for the suggestion.